Hello. Hi, Dolores. Hi, Greg. How are you? Hi, Kay. Thanks for sharing, Dolores. And Greg asks, how's everyone doing this evening? Well, I'm doing well, thank you. I see my head is cut off, so I'm going to fix that. Kay says, I'm okay. How about you, Greg Mallard? Carmen says, hello, followers and guests. Nice that you came to the show. Hi, Bonnie. Hi, Hulk. Bonnie says, hi, everyone. Greg says, if I were any better, I'd be twins. And Dolores says, from her YouTube perch, hi, everyone. Holly Horn says, hi, Holly. Greg says, I'm tuned into this and playing my video game at the same time. I'm flattered, Greg. And Carmen says, hi, handsome Greg. I'm doing okay. Thanks for asking. How are things with you in beautiful Georgia? I see you got out of FB jail quick. Kay says, share. Thank you, Kay. Share as much as you can. I didn't share as much tonight because I was short of time. Greg says, admit it, Joe, you love my jokes. I do. I do, Greg, no doubt about it. Okay, so state-based Medicare for all. I'll be getting to that. But before I get to that, I did want to cover one piece by Dean Baker that I thought was really important for you to hear about. So this one is called Vaccinating the World If We Had Grown-Ups in Charge. And this is from Counterpunch. Dean occasionally writes for Counterpunch. And he did a good one on May 27th, 2021. He says, people in policy debates are not supposed to question the desirability of patent monopolies as a mechanism for financing the development of new drugs and vaccines. After all, why ask a question that could jeopardize the profits of some of the world's largest corporations? But since I live out in southern Utah, far away from the great centers of policy debate, I thought I would ask the question in reference to vaccines against COVID. Dean, what are you doing out in southern Utah? I thought you lived here in D.C. To be specific, suppose that instead of funneling money into drug companies to subsidize the patent monopoly finance system, we instead used this money and added more to it for the purpose of fully pre-funding the development of vaccines. The condition of accepting funding is that all the work would be fully open source. This means that all the findings would be posted on the web so that researchers around the world could build on them. It also means that any patents would be in the public domain so that any manufacturers anywhere in the world could produce the vaccines developed through this system if they had the necessary expertise. The requirement for openness would also apply to the results of clinical trials, so it would be possible for researchers to know which vaccines were most effective for specific demographic groups and against which variants of the virus. This system would require some sort of international agreement on sharing research costs. While agreements can take time to work out, getting the numbers exactly right should not have been an impediment. In the context of a worldwide pandemic costing millions of lives and trillions of dollars of lost output, it is not a big deal if the United States or China pays 25% too much or too little. The simplest cost would be to agree to rough numbers with a commitment to re-examine the issue down the road. The open source alternative. Having raised the idea of open source research in various contexts over the last year or so, I realized many people are not familiar with the concept. The basic idea is that the research is fully open and posted on the web as soon as practical, so that any researcher in the world can read it and build on it. I've had people ask me why anyone would do research if they had to immediately share the results rather than secure a patient. The answer is, I'm sorry, secure a patent. Forgive me, a patent, not a patient. The answer is that they are getting paid for it. This is, in fact, the reason the vast majority of researchers are doing their work now. For the typical scientist at Moderna, Pfizer, or Merck, it doesn't matter whether these companies are making their money through ownership of a patent monopoly or through a government contract. They get a paycheck every month either way. I recognize that many scientists may actually be concerned about controlling a pandemic and saving lives, but I am not expecting that motivation to be a replacement for money in a paycheck. If the government is paying for research and can impose the condition that everything must be open source, if a company doesn't like the deal, it doesn't have to take it. That's pretty simple. This is a big deal with the current crop of vaccines being used, especially the mRNA vaccines, in addition to having already paid for much of the basic research developing mRNA technology through the National Institutes of Health. The government also paid for the cost of developing and testing Moderna's vaccine. Now, many people have pointed out that Moderna had invested in developing a platform that allowed them to quickly turn around and design a vaccine against the coronavirus. There is some truth to this. Arguably, the government would have had to make some additional payment to Moderna and likely other drug companies to get them to make all the information about their vaccines and their production process fully public. It would take some serious analysis to get a good estimate of a fair payment. But to put a rough cap on what we would be looking at in the case of Moderna, it would almost certainly be less than $2 billion and likely considerably lower with other manufacturers working with less novel processes. The Oxford AstraZeneca vaccine was developed almost entirely with public money, so there should not have been a need for any substantial payments to make it fully open source. As far as the $2 billion figure for buying full rights to open source Moderna's technology, it had a market capitalization of around $9 billion before the pandemic. Paying the company $2 billion for the technology directly related to producing the coronavirus vaccine would mean giving them almost 25% of the value of the company for this one specific line of work. Alternatively, we can envision paying $9 billion to buy the company and then selling off the components that are not directly related to producing a vaccine. If Moderna was reluctant to sell its rights for $2 billion or some comparable sum, the government could attempt to go around the company and simply pay its top researchers and engineers large sums, e.g. $1 million a month, to share their knowledge with the world. The government would also have to agree to cover all legal fees and settlements that could result from any subsequent lawsuits by Moderna. It is worth noting the logic of open source, which would actually make $2 billion sound very generous. Suppose that other manufacturers, but not Moderna, agree to buy out of rights and do future work as open source. This would mean first that Moderna would need to come up with $1 billion that the federal government paid to cover its development costs and phase 3 clinical trials. Even more importantly, Moderna would know that as soon as its vaccine had been through the testing and approval process, it would be competing with other vaccines which may be every bit as effective and selling as cheap generics. In addition, it would be having a very difficult time getting the necessary inputs, since the federal government would be using the Defense Production Act to steer all the inputs in short supply to produce the vaccines developed by companies that agreed to open source their work. In other words, Dean is saying, look, the government's got Moderna by the throat, and any of the other private companies too. So why not force open source? It's better for everybody. Also, the government could throw a large monkey wrench into Moderna's plans, he says, by demanding harsh terms for the use of an NIH patent that is essential to the vaccine. The government's rights to this patent could guarantee that Moderna would not be making big profits by refusing to come to terms. Many people have argued that these sorts of terms would destroy incentives for drug companies to develop vaccines in the future. This claim is difficult to understand. Presumably, drug companies undertake investment with an understanding of both risks of failure and expected payoffs. No one is proposing a situation where the drug companies would not be making a profit from the development of the vaccines for COVID. The issue is simply whether they would get a super bonanza from having developed a vaccine against the pandemic. This path takes away the super bonanza. So if we think about the incentive structure going forward, if governments just handed out patent monopolies, including on research that they had paid for, then drug companies can incorporate in their planning that there is maybe a 1 in 50 or 1 in 100 chance that will be a pandemic in the relevant time frame for their investment. If we pursue the route of forcing open source development, then the drug companies will not incorporate the low probability prospect of a pandemic super bonanza in their planning. We should be able to live with that. The impact on production. It would be difficult to determine how much vaccine production if we had gone the route of open source research and international cooperation. But it is likely that the gains would have been substantial. First and foremost, technology would have allowed for it to be replicated widely. If all the information needed to produce the Pfizer, AstraZeneca, or Sinopharm vaccines were posted on the web, then any government anywhere in the world with expertise in production of vaccines or related items would start converting or building a factory. BioNTech, Pfizer's German partner, bought a Novartis plant in the middle of September of 2020. It converted the plant to producing its mRNA vaccines. It now expects to be able to produce 250 million doses in the first half of 2021 and have an annual production rate of 750 million a year. This indicates a very rapid rate of turnaround. The Novartis plant was already a sophisticated manufacturing facility, so this surely saves some time. But there are other sophisticated facilities around the world which are not now being used to produce COVID vaccines. If there had been a clear international commitment to produce vaccines, even with the risks that some might prove ineffective or unneeded, this sort of conversion could have happened much sooner and with other facilities simultaneously. It would be an enormous risk for an individual company to spend hundreds of millions of dollars to convert a factory to produce a vaccine that may ultimately not be used. However, this risk is trivial for a government spending trillions of dollars to sustain its population through the pandemic. In fact, the purchase and conversion of the Novartis plant actually was funded by the German government. Also, while the mRNA vaccines have proven to be the most effective in stopping the spread, there are several other vaccines that have been approved by various government agencies. There are other vaccines. These other vaccines use different technologies, which should mean more facilities could be used and they would not be competing for inputs. Even if their effectiveness rate is somewhat lower, vaccines that are now 70 to 90% effective will still enormously slow the spread. Also, these other vaccines have advantages over the mRNA vaccines in that they do not have to be frozen. In the case of the Johnson & Johnson vaccine, they only require one shot. If we'd gone this route of full international governmental commitment, we also could have acted to remove bottlenecks in production, as the industry has repeatedly pointed out. Many of the inputs for vaccines are in short supply. According to Thomas Coaney, the Director General of the International Federation of Pharmaceutical Manufacturers and Associations, There is a major shortage of items like syringes and vials that is impeding the effort to vaccinate the world. This assertion can be found at 21.10 here. There's a link there. Well, even the best coordinated efforts might not be able to remove all bottlenecks. Surely we could have produced an adequate supply of syringes and vials 1 year into the pandemic. The other side of this sort of international commitment and open sourcing is that we almost certainly would have developed more innovations in the production process. Pfizer reported in February its engineers had figured out a way to alter their production process to cut the time needed almost in half. They also discovered that it was not necessary to super freeze the vaccine at minus 94 degrees Fahrenheit. It can instead be stored in a normal freezer for up to 2 weeks, which hugely eases the distribution process. Pfizer's production technology had been open sourced early in 2020. It seems hard to imagine no engineer in the world would have discovered the route to improve efficiency before February of 2021. There presumably are other ways to make its technology more efficient, which its engineers have not yet discovered. There would be a similar story with other vaccine manufacturers. Also, if Pfizer had open sourced its technology, it would be surprising if someone somewhere had not discovered it wasn't necessary to super freeze the vaccine before March of this year. In fact, the company did not even realize that its vials contained enough material for 6 shots rather than 5, a 20% increase for more than a full month after they were being widely distributed. The benefits in lives of money. There clearly were and undoubtedly still are huge potential gains from open sourcing the technologies used to produce the COVID vaccines and key inputs, as well as institutionalizing the production process. If this had been done when the pandemic first was recognized, we could have hugely increased the pace of vaccine output and gotten the pandemic under control more quickly. Given the possibilities for converting and building more facilities, as well as increasing the efficiency of the existing facilities, we can envision that we would have 2 or 3 times the number of vaccines as we do today. This would have had an enormous impact on lives and the economy. To get some idea of how a doubling of available vaccines might have impacted the course of the pandemic, it is worth remembering that the worst wave in Europe and the United States was hitting in January and February, just as vaccines were starting to be distributed. By January 15th, 3.2% of the population in the United States, with 10.5 million people, had received at least 1 shot. This was a period in which the number of infections was averaging more than 230,000 a day, and deaths were over 3,400 a day. If we had twice the available vaccines and a competent delivery system, this was still during the Trump presidency, we would have had 21 million people vaccinated at that point. This would have covered all our healthcare workers and the bulk of our older and most vulnerable population. Of course, of these people would have only had 1 shot, which means they don't have the full benefit of the vaccine. But the number of people getting seriously ill and dying would have been sharply reduced. By March 1st, we had vaccinated 15.2% of the population, or 50.2 million people. If we had twice the number of vaccines available, we would have vaccinated 30.4% of the population, or 100.4 million people. At this point, we would have enough vaccines to fully cover older people and others at risk. We were still seeing almost 70,000 cases a day at that point and 2,000 deaths. With this higher level of vaccination, the point actually reached at the start of April. The number of infections and deaths would be correspondingly lower. By the start of April, the number of infections was averaging just over 60,000 a day, and the number of deaths had dropped below $1,000 a day. If we maintained the doubling of our actual rate, by the end of March, almost 60% of the population, more than 195 million people, would have been vaccinated. On May 22nd, We are at 48.6%. At this point, increasing vaccination is a question of persuading vaccine-resistant people to get the shot. It is not an issue of supply. While it would be necessary to maintain a stockpile, additional production could be given to other countries. We also could envision that the economy would have been largely reopened by the beginning of last month. There's a similar story in Europe, which also saw its infections peak in January and February. In January, France was seeing 17,000 cases a day and almost 400 deaths. Italy averaged 16,000 cases and almost 500 deaths. And the UK over 50,000 cases and almost 1,100 deaths. The share of the population that was vaccinated as of January 15th in France, Italy, and the UK was 0.6%, 1.9%, and 5.3%, respectively. Doubling these rates would still only allow for a small share of highly vulnerable people to be vaccinated in France and Italy. In the UK, a 10.6 share would largely cover its healthcare workers and older population. On March 1st, these percentages had risen to 4.6% for France, 5.1% for Italy, and 30.2% for the UK. Doubling these figures would largely cover healthcare workers and the older population in France and Italy, and would imply that virtually anyone who wanted a shot in the UK had one. The hardest hit countries in the developing world, India and Brazil, could have benefited hugely from a more rapid rollout of vaccines. India hit its peak infection rate of just under 400,000 a day around May 10th. Its reported death averaged over 4,000 a day. These figures are almost certainly gross understatements, as testing is limited and many COVID deaths are going unreported. On May 1st, 9.2% of its population was vaccinated. If it had doubled this figure, 18.4% of the population would have been vaccinated. The share that would be large enough to substantially slow the spread and protect the most vulnerable segments of the population. In addition, with countries like the US and the UK having largely saturated demand by late March, vaccines could have been reallocated at essentially zero risk to help India cope with the pandemic. Brazil saw a peak of infections and deaths somewhat earlier. Its infections peaked at more than 75,000 a day in mid-March, with deaths averaging over 3,000 a day in early April. There is also serious underreporting in Brazil. Its vaccination rate was 4.5% on March 16th. A doubling to 9% would have allowed the country to cover its healthcare workers and most vulnerable population. As with India, Brazil could have benefited from vaccines being reallocated from the US, UK, and other countries that had satiated demand by the end of the month. It would be interesting to see a more careful calculation on the reduction in infections and deaths that would have resulted from doubling of the production rate, of vaccines. Okay, so you're getting the picture here. The rollouts could have been much, much faster. Well, he says, anyone who has any time in has spent any time in Washington policy debates knows that inertia is an incredibly powerful force. Really bad policies can survive for decades just because it's much easier to leave things as they are than to change them. This is clearly true for our system of patent monopoly financing of prescription drugs and vaccines. The pandemic is a full-out emergency that it should have led us to do everything possible to stem its spread as quickly as possible, coordinating as much as possible with other countries, even Russia and China, in a genuine international effort. Unfortunately, this was certainly not the agenda of the Trump administration. The result was many unnecessary infections and deaths and enormous economic waste. But we're some distance down the road now. We can still gain from taking the path of openness and cooperation. So I thought that was right on, and I thought you should hear about it. It's really an excellent piece. So onward to state-based Medicare for all. There was a Twitter thread which I picked up from Jules at Jules, Joules, 1971. Okay, Jules, okay, is an MMTer. And there's a lot to say in this particular thread. I will pick it up from the start. So, did I pick this up? Yes, I did pick this up from Jules. Anyway, the thread starts with a tweet from Dr. Joe Jarvis. I'm not going to go into this, but he is for Medicare for all in the state of Washington. A number of tweets were deleted from this as time went on. But Fran, Sylvia's daughter, said, this evil empire will never give us universal health care. We have to fight for this ourselves. Hashtag whole Washington. Whole Washington, okay, is an effort to bring Medicare for all to the state, okay, of Washington. Anyway, whole Washington /RB for Medicare for all has tirelessly put in the work. State by state is the only way. Hashtag M for all. Donate to wholewashington.org, calling for a donation. And there's a tweet of a meme from Ryan Knight here. Okay, a retweet of that. And the meme says, okay, and Ryan Knight is wearing a red beret and says, right now the Dems control the entire government and we can't even get a floor vote for Medicare for all. That's because the Dems are not the party of health care. They're the party of for-profit, predatory health insurance, big pharma, giant insurance companies. They are the party of capitalism and imperialism. And it's signed by Ryan Knight. That was his contribution. So Homie replied and said, I want to support your cause, but amplifying disingenuous hacks like Knight really hurts your credibility. So Red Berets, hashtag Medicare for all, hashtag 1362, replied to that. And this is the account of Laura Fielding, the executive director of the Red Berets, Medicare for All, and board member of Whole Washington, which is an organization in back of the effort to create single-payer health care for the state, okay, of Washington. And the tweet says, okay, the tweet from Laura Fielding, okay, or Red Berets, M for M all, is, this is a thing because of Act Proud Socialist. Act Proud Socialist is Ryan Knight. And then she links to a healthcare movie called healthcare.movie. Telling the truth and amplifying those who speak truth to power about our corrupt system does nothing to harm our credibility. But by the way, I've linked to this thread in the description, so you have access to the thread too. So, this was also, this by Laura Fielding, was also a retweet of a tweet from Kenny Ballantyne, who said, some highlights from the March 26th action in Tacoma, Washington for universal health care. And so Whole Washington, okay, and Red Berets, and a number of other activists, including Ron Placone, J-Man Prime, by Ryan Knight, Dr. Dooley, Dr. Joe Q. by Jarvis, were involved in the action in Tacoma. So this was an activist thing on March 26th in Tacoma, Washington. And then Are You Being Served, who's also a Red Beret, quoted, "This battle is heating up even among the various progressives," quote unquote. "Doing the unpopular, taking the bull by the horns is never easy. It usually doesn't pay well. Often folks get very uncomfortable, even angry at the pushback. This isn't go along to get along, hashtag state by state." And Red Berets replied, "Indeed, this is bottom-up strategy. Politicians and long-established single-payer orgs are used to controlling the strategy and the narrative. We, the people, however, understand that desperation is real. People are dying, and we can't wait until we unrig our corrupted legislature." And then Jules comes in on this thread for the first time. "State-based hashtag M4A will guarantee we never get national hashtag M4A. It will become the excuse to show why it won't work, why, quote, it won't work, that's scary socialism, unquote, and it's over. States are currency users that rely on taxes to pay for programs. The Fed government is the currency issuer and isn't so constrained." And there was a reply to this post from Jules by Jen Nye. And Jen Nye actually did a reply thread on her own. There are a number of consecutive replies from Jen Nye. "Hi at Jules 1971. Can you help me understand? I disagree and am confused by a few things. I think enacting this legislation will do exactly the opposite of what you say." Excuse me a second while I check that I am there in that picture. Yes. "Do exactly the opposite of what you say. Once the rest of the country sees how universal health care works, everyone will want it. It's only scary in theory." Well, that's an assertion. Okay, it's a prediction. It could be true. I'm sympathetic to it, but it might not be true. Anyway, Jen Nye follows up with, "There is a funding plan included in the legislation. It was developed by a single-payer economist, actually Gerald Friedman in this case, a very good economist, though, of course, a critic, okay, of MMT, but still a very good economist, good at costing things out, did some good work for Bernie Sanders. He's a post-Keynesian economist. He's a pretty good guy. It's probably a pretty good cost estimate." Anyway, Jen continues, "Yet it's based on taxes and premiums that go into a trust. When did funding programs by taxes become questionable?" I'm not sure when it became questionable. I don't know whether Jules was saying that was questionable, but from an MMT perspective, state-level spending is funded by taxes and premiums unless the federal government provides the money for such spending. But if the state is going to provide the funds for spending, then yes, it's based on taxes and premiums, because in most states, deficit spending, okay, is not allowed, nor do they issue bonds to underwrite any deficit spending. I mean, in most states, there's a constitutional provision prohibiting deficit spending in the state by law, by constitution. They have to do balanced budgets all the time. So, when did funding programs by taxes become questionable? At the state level, I think Jules would agree. It's not questionable at all. It's the only way to fund things at the state level. unless the federal government intervenes in some way. Jen Nye says, this plan, goes on, she says, this plan saves billions every year. If we're not printing currency now, why would the state need to print money when it's saving money? What dystopian future are you imagining? 1362 ends the waste and profit machine and saves $5 to $9 billion a year. I think that's the number of the bill that is introduced or being introduced into the legislature in Washington. I do want to point out here that the assumption is that the state, but the assumption in back of this particular tweet, okay, that I just read, seems to be that the state is already spending enough money on health care that just with that money, it could fund Medicare for all in the state. I don't know if that's what Gerald Friedman's analysis actually shows. I haven't had a chance to read it yet. But just off the top of my head, I would think that that's probably not enough money, because the money the state is spending is probably mostly on Medicaid. And while that's a substantial sum of money, I'm not sure, okay, that it would be enough to cover Medicare for all for the state, okay, of Washington. But I may well be missing something here. I think probably Gerald Friedman's assumption is that under the Affordable Care Act, that the state could obtain a waiver from the federal government and therefore get significant help from the federal government, in the sense that assistance to the states that would have gone in the Affordable Care Act would now go to the new Medicare for All program, and taking what the state spends now and adding that to it, that might be enough money that there would be no need for the state, okay, to appropriate any more spending, okay, than it already appropriates. The study by Friedman evidently estimated that $5 to $9 billion a year would be saved in Washington if they went for Medicare for all. So Jen Nye continues with yet another tweet. Okay, a lot of good people are pro #MMT, but wow, how heartless, how absurd these arguments are to someone that has a lump in their breast or an abscess tooth and no way to get health. Do we have to understand a macroeconomic theory before we demand our government end this shit show? I think that's a little unfair from Jen Nye, because there's a specific question involved here. And that question is, under what conditions can the state of Washington actually afford to provide Medicare for all their citizens? Let's assume that they wanted to actually provide Medicare for all along the same lines, okay, along the same lines as H.R. 1976, just a state-level version of H.R. 1976, which is the bill that has now been introduced into the House by Pramila Jayapal, who used to be a Washington a legislator in that state herself. So a state-level version, okay, of her bill. It's not a question of understanding macroeconomic theory. In this case, it's a question of understanding whether the state of Washington could afford to spend the likely spending that would be necessary to provide Medicare for all to everybody in the state of Washington. That is a specific question that can be answered, okay, by economic estimates. Of course, there would always be assumptions with respect to those estimates, but that wouldn't even be a matter, okay, of macroeconomics. I don't think that in the costing that was done by Gerald Friedman, that he had to make any recourse to macroeconomic theory. All he had to do was cost out what the state government would have to spend, and then consider whether the state government could somehow afford it. Jen Nye says, we have the initiative process. Wait, I lost the thread here. We have the initiative process. So this whole, quote, states can't XXS line needs to end. We can fund rockets that shoot hot dogs if we want, and the climate crisis is going to upend everything. I-1362 is right now. Right now. People are dying. How about you join us in the street? That was the fifth of her tweets. Then there was another tweet that was deleted by its author. That may have been a tweet by Jen, or it might have been actually a reply by Jules. I don't know. I could learn more. That doesn't really provide any information that I could possibly use. So anyway, Jen Nye then tweeted again. We don't need 50 states to do this, just one or two. They'll prove it out. We'll move to a federal policy. That's the ultimate goal and always has been. Please stop acting like regular humans have no business fighting to get profit out of healthcare. I don't know who's acting like that. I don't believe Jules K is acting like that. I think I'm just asking, okay, a reasonable question. Does Washington, is it a large enough state to have the fiscal means to do this by itself? Perhaps it would be prudent for Washington to seek an interstate compact with Oregon and with California, both of which states are overwhelmingly for Medicare for all. Certainly with Oregon and California thrown in, I think we're talking maybe 55 million people there. Certainly that's a big enough region that it would have a similar fiscal capacity to fund Medicare for all to, say, France. We know France can fund a program. It's very similar to Medicare for all. So certainly a regional collection of states like that would most probably be able to fund Medicare for all successfully, even if it had to fund it out of taxes. That's just an opinion that I'm offering here. More tweets were deleted by the tweet author, whoever that was. Jen says, I'm not listening to any economic theory that tells me not to try. Like it or not, I-1362 is the game in town. And knowing the condition of actual human beings, this is the least we can do. If MMT is against actively taking a stand here, BCS books, I want nothing to do with it. I'd just like to add to what Jen had to say here by saying, certainly economic theory, MMT, okay, as an economic lens, does not actively take a stand here. It's a lens for analyzing the economy. What it will tell you is that the state of Washington is not a currency issue, that it can possibly go broke, it can possibly be bankrupt. And therefore, it's not in as good a position to have a Medicare for All program as the United States taken as a whole, which is a currency issuer, which is a monetary sovereign. That's what MMT will tell you. Whatever else is being inferred by the MMT partisans who have been active in this particular thread, what they're saying isn't necessarily based on the MMT lens, but inferences they're drawing with the aid of other assumptions concerning whether the state of Washington is likely to be able to carry through this successfully. I'm not saying the objectors are wrong. I'm not saying the objectors are right. What I am saying is that the supplementary assumptions are not part of the MMT lens. They're supplementary assumptions being added to the MMT truths that come out of the lens. Perhaps the supplementary assumptions are valid. Perhaps they're not valid. If they're not valid, then the arguments of the MMTers who've been offering these opinions would not be valid. But it should be recognized that supplementary assumptions being added by the MMT economists are not part of MMT itself. That is part of a political application of MMT that they are engaged in at this particular point. That political application could make sense, or it might not make sense. You have to judge the arguments on their merits. And you shouldn't be looking at it, oh, this comes from MMT, so it's got to be wrong, or this comes from MMT, so it's got to be right. You use the parts of MMT which are useful in reasoning about how this is going to go down. And you note very carefully what the supplementary assumptions are and whether they make any sense or do not make any sense. One thing I can say for sure, though, MMT as a descriptive lens is not against actively taking a stand here. You can't draw that out, of MMT. You cannot draw that out of the simple notion that the state of Washington is not a monetary sovereign and therefore has less policy space associated with it than the federal government has. I mean, we all know that that's true. In other words, the federal government has a lot more policy space than the state of Washington. But that doesn't mean that the state of Washington doesn't have enough policy space to support a Medicare for All program. And it certainly doesn't mean that if it combined with Oregon and Washington, that it would not have a sufficient amount of policy space. So Georgia here, George Davenport says, I'm amazed. These people think they know more about the economics of single payer than Dr. Gerald Friedman, who has proven states can do this and save billions. Well, I, for one, don't think that I know more about the economics of single payer than Dr. Gerald Friedman from the standpoint of how much single payer in Washington is likely to cost. He's been studying it carefully. I haven't. He certainly knows more than I. The question is not that. The question is whether he knows enough to be able to say in a definitive way that if the state of Washington passed such and such a Medicare for All bill, it would be able to afford the costs of that particular Medicare for All bill. And by the way, Georgia, I have no doubt that if Medicare for All were implemented by the state of Washington, it would, as you say, and period, save period, billions, period. It would do that. And it would save an awful lot of lives in the process also. Georgia goes on, also attacking fellow hashtag M4A supporters seems like an awful waste of time. Why not pester anti-Medicare for all politicians instead? And Jules then says, open-mindedly, I think, I would be interested in any available links to Friedman's assessment of state-by-state implementation. We'll visit whole Washington website to see if it's there. Jen Nye replies and gives the link to Jerry Friedman's analysis, which I now, by the way, have also myself, and I'm looking forward to reading in detail. And Jules says, yes, I found that myself too. Where's the previously mentioned analysis of the rollout of state-by-state Medicare for all, proving that it's a workable option? I don't see that. Georgia doesn't provide a link, but says, I think the real-life example of Canada passing this province by province, is a good one. Well, there is something else we should take a look at in relation to the Canada comparison. So for the moment, I'm going to depart from this particular thread. I will come back to it shortly. And what I will share now, since it seems very apropos at this point, is a piece by Margaret Flowers that she did in 2018 for her own website, Health Over Profit. Now, I want to say, in going into this, there are very few people in this country who are more knowledgeable about the ins and outs of Medicare for all than Margaret Flowers is. I've known Margaret since 2010, since 2009 actually, the fall of 2009, and I've read a lot of what she's written on the subject. She knows Medicare for all inside and out. Which path to national improved Medicare for all? Oh, by the way, though, she isn't an economist. She happens to be a doctor, a pediatrician by training. But she has been studying Medicare for all for 2 decades now. She's been on the board of directors of PNHP, and that's the Physicians for a National Health Program. And she's an MD, of course, as I said, but after 20 years, she's an excellent and very credible policy analyst concerning Medicare for all. Anyway, here's what she has to say about state-level reforms. She says, state-level reforms for universal health care are laudable. They're not single-payer. 2 states with a long history of state-based health care reform efforts, California and New York, are hard at work organizing, this was in 2018, organizing for state bills labeled as single-payer health care plans. Other states are moving in that direction too. This raises questions by single-payer advocates. Can states create single-payer healthcare systems? Does state-level work help or hinder our goal of national improved Medicare for all, also known as NEMA, N-I-M-A? The movement for NEMA gained momentum throughout 2017, largely due to rising premiums under the Affordable Care Act and Republican efforts to worsen the healthcare crisis. Supporters of NEMA mobilized to build support for single-payer legislation in Congress, spoke out at town halls, and pressured the lawmakers. As a result, the House bill, H.R. 676, the expanded and improved the Medicare for All Act, grew to 120 co-sponsors, the highest number in its 15-year history, and Senator Sanders was successfully pressured to introduce a bill in the Senate, S. 1804, the Medicare for All Act. As momentum grew, the expected pushback materialized. In the spring, Democrats in Congress urged people to focus on fixing the Affordable Care Act and uttered support for various forms of public insurance, a, quote, public option, unquote, or Medicare buy-in. In August, well-known progressives claiming to be, quote, single-payer supporters, unquote, published articles arguing that single-payer was too much to ask for and outlining, quote, incremental approaches, unquote. But by the way, this is exactly what happened in earlier times. For example, in 2009, John Conyers introduced an earlier version of H.R. 676 right then. Okay? People who uttered support for various forms of public insurance were touting a public option at that time. They touted the public option for nearly a year and a half before they abandoned the idea of the public option. The public option at that point was a trick sparkle pony designed to divert attention away from Medicare for All. It was very successful in doing that. This is a rerun of those earlier tactics. This is what's been going on the last 2 or 3 years. Every time Medicare for All pops up with a bill or something like that, you hear the same chorus of people. Well, we love Medicare for All. We'd love to have it, but it's not practical right now, so we need a public option. This is a ritual by now. The public option trick sparkle pony. In August, well-known progressives claiming published articles on, I'm sorry, I said that already. Members of Congress, including Speaker Nancy Pelosi, complained about Democratic voters making single-payer a litmus test in the next elections. And by the way, only way we're going to get Medicare for All is to make it a litmus test in the next elections. Pelosi said, so I say to people, if you want single-payer, do it in your state. States are laboratories. The message was clear. There was too much pressure for NEMA. Democrats didn't like it. Sending people to work at the state level would lower the heat on Congress. So now what Margaret is doing is she's bringing up the political problem. Okay, the political problem. That is, the opponents of Medicare for All are trying to take the heat off the national decision makers and are saying, leave us alone, go do it in the states. So here we have state efforts. Canada is often pointed to as a model for achieving NEMA in the United States. The universal medical insurance was first created in the province of Saskatchewan in 1962, following decades of increased socialization of medicine in several provinces and a national law that financed universal hospital coverage at the provincial level. By 1968, the universal publicly financed Medicare program was adopted nationally. Could the same path occur in the United States? 21st century healthcare system in the United States is much more complex than the Canadian system was in the 1960s. At that time, healthcare was left up to the provinces. Dr. Don McCann, another doctor from Physicians for a National Health Program, writes, quote, we cannot use the example of Saskatchewan and pretend that a state can set up a single-payer system that could serve as an example for the nation, a model that could be expanded to all states. No, Saskatchewan began with a tabula rasa. They were able to create a de novo single-payer system, unquote. Rather than socializing medicine, the U.S. has experienced decades of increasing privatization. There are a multitude of payers in the United States, which include private insurance through employers, unions, and individually, public programs and national programs for federal employees and the military. A state would have to succeed in obtaining multiple waivers from the federal government and changes to federal laws to enact a state-based program. One federal law, the Employee Retirement and Income Security Act of 1974, ERISA, which prohibits states from regulating employee benefits, is a major obstacle. States also face the hurdle of being required to balance their budgets, a barrier that doesn't exist at the national level. As outlined in Public Citizen's, quote, roadmap to single payer, unquote, a state can potentially make its healthcare system more efficient, but it cannot achieve a single payer system. Thus, it can't attain the bulk of savings that a single payer system would have. Within their budget constraints, states would be forced to raise the cost to individuals and businesses or lower coverage if they are not able to meet their needs for care. This has happened in every past attempt by states to achieve universal coverage, as Doctors Steffi Woolhandler and David Himmelstein document in State Health Reform the Flatlines. So there's a reference to a piece by Steffi Woolhandler and Himmelstein in one of their earlier studies. They also are two people who know more about Medicare for All than almost anybody that you could name. They've been pushing for Medicare for All, as far as I know, since the 1990s. If a state were able to pass a bill outlining a path toward a universal healthcare system and to be granted a federal waiver from the Affordable Care Act, which are major feats, the state would still face significant barriers, some of which make it impossible to create a pure single-payer program. Barriers to state single-payer. 1. Federal health plans. There are numerous federal health plans, such as Medicare for seniors and those who qualify for disability, the Federal Employee Health Benefits Program, which includes over 200 plans, the Veterans Health Administration, the Indian Health Service, and TRICARE for members of the military. It is not possible to merge all these programs into a single-payer system. Well, politically, it would indeed be very, very difficult. Even in H.R. 1976, the Veterans Health Administration, the VA, and the Indian Health Service are not merged into H.R. 1976 at the start, at least not for a while. The Center for Medicare and Medicaid Services does not have the authority to give federal Medicare dollars to the state as a block grant. Single-payer advocates have opposed passing a federal law that would allow this due to concern that it would dismantle the Medicare program state by state and allow some states to use the law to further privatize Medicare through vouchers. This last objection is a very, very important objection because seniors would never want to take a chance that they would lose their Medicare. No senior would want to take that risk if they have Medicare on now and are not sufficiently rich to go full bore in paying their whole healthcare bills. Most every senior, 95% of seniors, rely on Medicare and we'd be happy to have upgrades, of Medicare, expansion of coverage, in Medicare, the lowering of copays and deductibles, in Medicare. However, we would in no way want to risk having a state that we were in fold the national Medicare program into a state Medicare program, so that we could no longer participate in the national program if we had to. She goes on. Some state advocates have considered applying for a new state health care plan to be considered a Medicare Advantage plan. These are private plans offered under Medicare. If such a waiver were granted, the state still could not force seniors to choose the state plan, so it would only capture some of the Medicare recipients in the states. There is a similar situation with the health plans for federal employees. It would require a change in federal law to shift the FEHBP to the state. That's the federal employees' health plan. Perhaps the state could apply to be considered a choice for federal employees, but even if it succeeded, it could not compel federal employees to choose their plan. TRICARE is a program run by the Department of Defense that would also continue to operate outside the new state system, and the VA and the IHS would operate independently as well. Now, all these are key objections. And without a federal dispensation, it would be impossible for a state Medicare for All program to tap into the federal funding that was being provided to these other federal programs. As she says, CMS doesn't have the authority to provide any block grants to states using funds that were allocated for its programs. She goes on. It is possible, though, although this has not been tried yet, that a state could become an intermediary between providers in the state and the various federal programs. Such that claims would be submitted to the state, and the state would collect the payment from the federal program to pay the provider. This would add more administrative complexity and cost to the state program, and providers would still have to interact with the individual plans for authorization of care. Item 2 here, okay, is Medicaid. It's a federal program for people with low incomes administered at the state level. A state would have to apply for a waiver to incorporate Medicaid into its new state program. There is greater flexibility for a state to do this than there is for Medicare. States would still have to track how many people qualify for Medicaid to be reimbursed for them by the federal government. And other administrative tasks that adds costs, so would need to ask for a block grant. Single-payer advocates have opposed turning Medicaid into a block grant program because that would limit funds during periods of recession when more people qualify for Medicaid. A block grant would not expand as the need expanded. All states except Connecticut use a mix of private insurance managed care organizations for Medicaid patients. To streamline its Medicaid system, a state would need to get rid of its multiple Medicaid managed care organizations. 3, employer health plans. Employee benefits are protected under a federal law, the Employee Retirement Income Security Act of 1974. While states have the authority to regulate health insurers that operate in their states, they do not have authority to regulate plans offered by businesses that self-insure, which is 60% of businesses that provide health benefits. Any interference in employee benefits can be challenged under ERISA and would result in a lengthy and expensive court battle. California and New York are trying to circumvent ERISA by stating explicitly that their state program, quote, does not create any employment benefit, nor does it require, prohibit, or limit the providing of any employment benefit. However, a state system would be challenged under ERISA, and recent ERISA challenges have not been favorable. Case between the state of Vermont and Liberty Mutual, which operates an ERISA plan, went to the U.S. Supreme Court in 2016, was decided against the state. The case involved a law regulating insurers to report claims data. Even though the Vermont law did not specifically target ERISA plans, it was determined to be preempted by ERISA because it had a connection to the ERISA plan. Another impermissible connection would occur if economic effects of the state law force an ERISA plan to adopt a certain scheme of substantive coverage or effectively restrict its choice of insurers. A state law requiring businesses to pay a payroll tax would likely be viewed as restricting choice. States can strive for universal coverage, but calling state plans single payer is incorrect. For many decades, states have introduced and passed laws aimed at achieving universal health care coverage. None has yet succeeded in being universal or sustainable, but these are admirable efforts that have increased access to care, at least temporarily. It is possible for a state using the roadmap outlined by Public Citizen to move towards a universal coverage. It is not possible to achieve a pure single-payer system at the state level, and so states forego the significant savings of a single-payer system. In the drive towards a universal health care, states might, I should mention, at this point, that this statement should be compared against the claim, by Gerald Friedman, that 5 to 9 billion would be saved by a Medicare for All program for the state, for Washington, as a state. Because while this claim that states forego the significant savings of a single-payer system may or may not apply to all of the states, in the United States. If Gerald Friedman is correct, that does not apply to Washington, since they will be saving, according to him, if he's right, somewhere between $5 billion a year and $9 billion a year in savings. Those are significant savings. In the drive towards universal health care, states might consider working to get rid of private Medicaid MCOs, as Connecticut did, so that more Medicaid dollars are available to cover more people and or more care. Oklahoma had a similar program that was successful. Part of the success of these programs is providing case management for people with significant health needs to avoid preventable emergency room visits and hospitalizations. Given that states are not able to achieve pure single payer, states take a risk when they label themselves single payer or Medicare for All. While it is understandable that these terms are popular, that most advocates for healthcare reform support single payer, so are inspired to work for it, it is misleading and could harm national efforts. For example, Vermont passed a law in 2010 requiring the state to develop a plan for universal health care coverage. That law allowed the state to contract Dr. William Sayo, who assisted in the design of the Taiwanese single-payer health care system in the 1990s, to design their system. Vermont's system was not a single-payer system, yet it was consistently called single-payer by the governor, advocates, and the media. It failed, and its failure was blamed on its high cost. Actually, it was never implemented. What happened was the governor stepped away from it when a consultant he brought in from MIT, if I'm not mistaken, made the case that Vermont would not be able to afford the so-called single-payer system that it was considering. By the way, the consultant that was called in by Vermont had been a consultant for the Affordable Care Act in the Obama administration. And for my money, clearly had a bias in favor of something like the Affordable Care Act. He'd also been a consultant for the state of Massachusetts when it was developing its healthcare system, which the Affordable Care Act was based on. And by the way, the Massachusetts healthcare system was based on a proposal from, if I recall correctly, the Heritage Foundation. It was a Republican-inspired plan. So this consultant who was brought in by Vermont to evaluate Dr. Sayo's design was someone who in the first place was most probably biased against a single payer and whose analysis was likely not to be trusted. Similarly, Colorado attempted universal health care coverage in 2016 through the creation of a statewide publicly financed healthcare cooperative. Colorado Care would have replaced most private health insurance and taken over the Medicaid program in the state for the poor and people with disabilities starting in 2019. The ballot initiative did not seek to replace Medicare benefits or current health care coverage for veterans, military personnel, and civilian defense employees. The Colorado plan was called single payer, even though it wasn't, and its defeat was marked in the media as a second defeat for single payer health care. Prominent Democrats opposed Colorado Care. Some progressive groups in Colorado also declined to support it, saying that single payer can only be done at the national level. It is hard to argue with them when they are correct. It undermines our legitimacy if single payer advocates are on the inaccurate side of that argument. Do state efforts help or hinder national efforts? Advocates for single payer, quote unquote, the state level often say that state efforts will help national efforts. Some advocates work for reform at the state level because they believe the public will be more inspired to fight for change at the local and at the national level. It is true that it is often easier to engage people around local or state efforts. They feel more winnable. But what happens when the public is told they're working for state-based single payer and they find out that they have been misled because the goal is not possible? It may be that public trust is lost or that people experience a deep disappointment because they work hard for something that will never be realized. And what would happen if a state succeeded in passing a health law? First, it would take a tremendous effort focused on influencing state, not national legislators to pass it. Second, that level of state-based pressure would have to be maintained to implement the law. And third, a state campaign would be so focused on these efforts that it would have little time or resources to advocate for change, at the national level. Their national fight would be aimed at applying for waivers and winning changes to the Medicare law, and ERISA. So what she's saying here, of course, and what lots of the advocates for a national Medicare for All program are afraid of, is that heavy state-based efforts, such as the push by whole Washington, what they're afraid of is that the activists within Washington cannot walk, talk, and chew gum at the same time. That is, that if they put their whole hearts and souls into the state effort, they will not be able to do the same at the same time for the national effort, but will be diverted by the state effort. And of course, there's a legitimate worry that the efforts of activists will be divided between the state level and the national level, thus weakening the movement for Medicare for All as opposed to strengthening it. Imagine if a highly populated progressive state, says Margaret, such as California and New York, were to drop out of the national effort for NEMA to focus on their state. This would be a huge loss. Dr. Woolhandler reminds us, quote, living in New York or Massachusetts doesn't lessen our sense of responsibility for millions in the Deep South and other red state areas for whom national legislation is the only realistic option for healthcare progress, unquote. The only way we will achieve national improved Medicare for all is if we develop a movement of movements and strategic campaigns focused on that goal. It is going to be a fight, but it is a winnable fight, especially now as the ACA becomes unsustainable and Congress threatens the minor safety net currently in existence. To win, we need to continue to build momentum in our states to pressure members of Congress. This election year is a perfect time to do that, particularly during the primaries when candidates are sensitive about their image. We need to connect our fights to other struggles to protect public insurances such as Medicaid and Medicare. The solution to preserving our social health systems is to make them be universal. Then we have the social solidarity, everybody in and nobody out, to protect and strengthen them. That everybody in and nobody out, that is a tremendously powerful appeal if we would use it in national politics and use it unremittingly and uncompromisingly. Because what it's about is not me, us. Everybody in and nobody out. The study of social movements shows us that we are close to winning NEMA. The power holders will predictably work to throw us off track by sending us down false paths of partial reforms and state-based efforts and lure us into working on elections. We must recognize and resist these distractions. We will win when we have built the popular power to shift the political culture so that no politician can be on the wrong side of this issue. We win when there is a loud and clear public demand for national improved Medicare for all. So, I think that's a very good argument from a partisan for national improved Medicare for all, one who's worked for it for decades. Okay? I'm not saying she's right. I'm not saying there's no possibility of state-based Medicare for all. I present this as a counter-argument. However, I think this counter-argument is actually more convincing than the simple MMT argument that the states are not currency sovereigns, because we see in Europe, and we see in many places of the world, because all kinds of monetary sovereigns in the world have not been acting like they are monetary sovereigns, and they still manage to adequately finance a Medicare for all program using, I shouldn't say using tax revenue, because I know very well they don't use tax revenue, but essentially offsetting Medicare for all expenditures with taxation dollar for dollar. They're doing that. They've been doing that. They haven't been going bankrupt doing that. And of course, in the case of the nations of Europe, many of those nations are doing something similar to Medicare for all, or nearly the same, as Medicare for all, and they're offsetting it fully with taxes. So the idea that if you have to offset the costs of Medicare for all with taxes, and doing that is impossible for political units of a certain size, is not borne out by the empirical evidence over in Europe, and in other parts of the world. In Belgium, a very small country, they have a wonderful healthcare system, and that is funded largely by taxes. They can run only very small deficits because they're limited by the criteria of the Eurozone. That's been the case in France too. That's been the case in Spain. All those nations have, by universal healthcare systems, they've been able to afford them. The reason why they can afford them is because of the savings. I haven't looked in the last few weeks at what we're up to now. Last time I looked, we were at 18% of GDP spent, on healthcare spending, and we were on our way quickly to 20%. By 2022 or something like that, it was going to be 20%, of GDP. These other nations are spending 9, 10, 11% of GDP, sometimes even less. In the Taiwan healthcare system, they have it's disputed about whether they have a country or not, but they have a government with 24 million people. They have a Medicare for all system that is based on our Medicare system. They looked at our Medicare system. They brought over our Medicare consultants, people from the Brookings Institution, to design their system during the 1990s. And now they have nearly 100% coverage. Long ago, they had nearly 100% coverage. And they spend something like, I don't know, it's 6-7% of GDP. And everybody goes to the doctor every time they want, free of charge. These programs save money, and they can be afforded. So, when you consider whether you can do a state-based Medicare for all system, you have to look at other examples of governmental units that are only a fraction of the size of the United States and that are managing systems similar to Medicare for all very, very successfully, even though they are not monetary sovereigns. And then there are also lots of other states that are not acting like monetary sovereigns, such as Australia, which are not having any problems funding their system. New Zealand, not having any problems in funding their system. They're not doing it through deficit spending. They're offsetting the expenses with taxes. So, I only covered a fraction of what I wanted to cover today. I'm going to halt it here. What I want you, however, to know, okay, is to know that I'm going systematically through a set of pieces. I'm using the Twitter thread as kind of a benchmark. Okay, I'm introducing some articles that are critical of the idea of using state-based type of Medicare for all system. I've covered one of those articles thus far and some of the Twitter thread. Tomorrow, I believe sometime tomorrow, but it may not be till Thursday because my daughter is here and I'm not sure whether I'll be available tomorrow night, okay, at the specific time, okay, that I'm usually on. So I may be doing it some other time, okay, tomorrow night, okay, or I'll certainly be coming back on Thursday and taking this up again, okay, at that time. But in order to give you a preview, I'm coming up, I'll be at you again with another argument against a state-based Medicare for all. Then, after that, I'm going to talk about, okay, an article that introduces what looks like it will be a new development based on an old development that is coming once again to Washington. Specifically, the revenue sharing idea is getting resurrected by the powers that be. And that has potential for state-based Medicare for all systems. So that's a new development. I think it tends to weaken some of the anti-state arguments for state-level Medicare for all. After I do that, I'm going to go over Ro Khanna's ideas on state-based Medicare for all. And then I'm going to come up with an assessment being very clear about the possible role, okay, of MMT in assisting the development of state-based Medicare for all. Okay. But now, okay, I want to mark the place, okay, where we are, Georgia, in the thread. Let me just briefly share that again. Georgia, George Davenport, that is. Was answering, okay, a reply by Jules. Said, I think the real life example of Canada passing this province by province, okay, is a good one. Okay, and then we go on to other tweets in this rather long exchange. And so I'll be taking that up again tomorrow. For now, I'm going to move to your comments. And as I say, I'll be back tomorrow with, I hope I'll be able to finish the rest of this tomorrow. Okay, and bring it to conclusion, but to give you little coming attractions. Okay, I've been giving you the negative first, and then I'm going to move into the positive, and then I'm going to introduce the possibilities, how the monetary sovereignty of the United States can assist the Medicare for All movement at the state level. And then, of course, in the end, I'll round out the whole thing by talking about the politics of this. So, I'm going to go now to your comments. Thank you for being patient. Here we are again. I see quite a few of you are here. That's good. Okay, I like that. And I'm moving to your comments now. Greg says, we're the best discussion group on the interwebs. Kay says, I think so too, Gregory Mallard. Carmen says, same. Amber says, Dr. Joe, your voice of reason was so welcome regarding old Washington. Thank you. Thank you, Amber. Thank you, Amber. Hey, I'm glad you thought so. Kay said, hi, Steve Gonzo. And Steve says, Greg and I made our friendship official today. Great. Steve Gonzo said, but Gregory Mallard, can I call you Greg? Greg says, I have the Moderna vaccine. Terry Burke made it. No kids tonight. I have my vino and listening to the best progressive talk show online. Thank you, Terry. Carmen says, hi, Terry. Glad you made it. Terry says, hi, beautiful Carmen. I'm glad I made it too. We'll be in Miami next weekend. Maybe we can click up. Carmen says, I have to go to Central Florida this weekend. Sorry. Carmen says, I read Pfizer is causing heart problems, especially in the young. I don't know about that one. And Greg says, this is why the federal government should be taking over these industries. Steve Gonzo says, what good is $1 trillion COVID rescue bill when only a small fraction of the allocated funds get distributed locally? Jordan, status quo, with Grumbine discussed this today. Carmen says, Bonnie, get the water ready. Kay says, I saw on the news today that one of the vax makers is thinking they can make a vax for lung cancer. Shake my head. But been done in Cuba for many years, for several years now. Well, I guess we should be able to do it here then, with all of the billions and billions we're going to spread around. Steve Gonzo says, $1 trillion remains to be dispersed as the economy recovers. Some of the money might not even be spent. What a tragedy. The economy needs it all. Carmen says, Rebecca Jones received whistleblower status. Just think. The anxiety of fascist #death Santist running for president next. Lana says, hi all, I just realized you were on. I tweeted you, Lana. I tweeted you before the show. A good deal before the show, like a half hour before the show. Kay said, Vietnam now has a variant of the India and some other kind. Not good. Yes, not good at all. That's a mean one. And Steve says, hi all, just stopped by to share watching on Facebook. Thank you, Steve. And Carmen says, there's a Medicare for All protest coming, but I couldn't find the details, date, location. It's July 24th. I think it's going to be countrywide, but there's going to be a particularly big one here, okay, in D.C. Look it up on National Nurses by United. They're pushing strong for it, Carmen. Kay says, we have a group here in Ohio, too, called SPAN, Single Payer Action Network. And Carmen says, Florida passed sports gambling betting with the Seminoles. Bad for gamblers or their children. Not sure if it's good for state revenue yet or if the crooks will just pocket it. Kay says, I'm still dealing with Ohio Medicaid. Shake my head. What a hassle. All states need to do is accept expanded Medicare. No, it's expanded Medicaid at this point. Kay says, if Medicare was expanded to include dental, hearing, and glasses, okay, I might not have to deal Medicaid at all. There are some Medicare Advantage plans that cover dental, hearing, okay, and glasses. I think the dental is still pretty expensive. Still pretty expensive. I don't know how good the hearing, okay, and the glasses coverage is, but we're paying for an expansion, okay, of Medicare right now for that through Kaiser, and our premiums are $47 a month per person, so they're not really too heavy for the expanded coverage. And Lana says, I'm eating my dinner, so not typing right now. Steve Gunzo says, maybe someday Joe Biden will be in a position of power. Then he can start fighting for his agenda. Yeah, the Biden Record Group. Steve Gunzo, he puts himself in the position he is in by insisting on bipartisanship. He needs to grow some balls and do what he needs to do. Kay says, Schumer needs balls too. Well, don't you know? Schumer made a public statement saying that his name in Hebrew means guardian. Steve Gonzo says, speaking of balls, Trumple Foreskin says he'll be reinstated as prez by August. Oh, yeah? I don't think so. Kay says, Steve Gonzo, he wishes, laugh out loud. Kay says, he's hoping he isn't in jail by then, laugh out loud. Yeah, he's gauging his fanatical fascist base, probably about to hit them up for donations. Kay says, I have heard that the DeSantis can prevent Rump from being sent to New York to be arrested. I hope that isn't true. He may be in a position to block the extradition, but I understand that Trump is planning a trip to New Jersey at some point. Steve Gonzo says, not true, plus he's going to New Jersey. Kay says, good. Terry says, he hasn't gone yet. I don't think he will. Carmen says, ooh, I thought you were about to say the consultant that was brought in to Vermont was the parliamentarian. No, this guy was a male consultant from MIT. Kay says, there were several reasons he moved his home to Florida. Kay says, if we had Medicare for all, I could go back to North Carolina and shake my head. Well, maybe North Carolina, no, they would never pass Medicare for all down in North Carolina. They would have to completely redistrict the legislature in order to do that. Steve Gonzo says, Biden budget boosts ICE by $18 billion, hashtag harm reduction. Well, he did say Latinos weren't part of his campaign strategy. Oh, God, it got so awful. But Lana says, I was in training for 9 hours today. Didn't see your tweet immediately. Oh, okay. Joe Manchin says, Manchin likes bipartisan talk too. Could be ridiculous. GOP isn't interested in any compromise or working together. Sick of weak tea Democrats. Thank you, Lana. Steve Gonzo says, Secret Service is spending nearly $35,000 to rent portable toilets for the next 4 months in Bedminster, New Jersey, where Donald Trump is apparently spending the summer. Well, if he goes to Bedminster, he's going to be extraditable to New York then. So maybe Letitia James is watching that very carefully. Okay, folks. I think I've done it for tonight. I hope you like this one so far. There'll be more fireworks tomorrow as we move into more negatives and then start moving into the positives. And I think you'll find the whole thing very, very interesting. I hope so. Anyway, try to get as many as you can to come. And Lana says Bedminster, high dollar area. Yeah, Trump is there, so I guess it's a high dollar area. Dolores says thank you and good night all. Thank you for coming, Dolores. Thank you for sharing. Thank you for all the work you do on behalf of this program. I really appreciate it. And I appreciate all of your work too, Lana. Very, very much. And thank you all for all the sharing you do. I will see you tomorrow. Kay says, thank you, Joe, and all. I always love these discussions. Love you all, and we love you, Kay. Steve Gonzo says, great show. I was in the middle of that thread. Oh, so I'm going to see you when I go back to that thread, right? I hadn't seen you yet in that thread, but I'll definitely look for you, Steve. And maybe I did see you in that thread. I'm going to double check it anyway. So I'm ending the broadcast. Thank you very much and good night.